Okay, this is studies that, one of the most famous studies is Dr. Kilmer is a pain specialist in Canada, had worked a lot with studies. He's a neurosurgeon, one of the pioneer guys who did a lot of studies in the past. And what he did, he studied patients with spinal cord stimulators and conventional medical management versus patients on conventional medical management only with failed back syndrome, spinal syndrome. And he did a prospective randomized controlled trials. The only bad thing is found by a company, but it's very hard to do those studies without a found by a company. But he's a very serious doctor. He used also multi-center trials, so they went different ones, Canada, Australia, Europe, Israel, and they really went for 2003 to 2005. And what they found, we're going to go over to the findings, but they did it like they study the patients. The patient was allowed to cross over if it wasn't working after 6 months of treatment. And what they found, 6 months achieved in spinal cord stimulator was 48% improvement with only 9% on conventional methods. In 12 months, spinal cord stimulator still maintained 48, and we had some increase in conventional methods, but it's still below of the dorsal column stimulator. And if treat all crossovers after 6 months as failure, then spinal cord stimulator was 34 and conventional method 7. If excluded 5 patients in the spinal cord stimulator who failed trial but were still implanted, we go up to 51 versus 9. So really, we have a lot of success with dorsal column stimulators. And he also later on did studies with cost effectiveness, and he also proved cost effectiveness in 3 years with dorsal column stimulators. That's good. Those are the complications. Okay. So failed back syndrome is difficult to treat. Strong evidence that the spinal cord stimulator is a good option for neuropathic pain associated with failed back syndrome. Due to incidence of complications stimulators, it cannot be the primary treatment. Well, when you talk about complications now, we're talking about migration of leads, breaking of leads, and small things like that. There was one case of complication of infection. So really, what that means? Just means that a patient comes in the room and you look at them and say, well, they have radiculopathy going to the leg, let's put a stimulator on. So that's not how we do it. We have to go into our steps. But also, on the other hand, we also learning that we don't want that patient to become too chronic, too ill to decide upon stimulator. So once we do our steps, so is it, and the consideration that I do is this patient going to require a very complex modality of conservative management, means severe high doses in opioids. I have to be adding on drugs to counteract the side effects of the opioids. Then another drug to counteract the constipation. Then another drug to wake the patient up. Then another drug to make them sleep at night. So when they start to go that way, I start to think about something else. If a patient comes in and I put a 50 micrograms patch, they're doing fine, they're working fine, I'm not going to be thinking about stimulator for that patient. They're okay. I mean, they're not calling me, they're not complaining every month that the pain is going up. So that the patient is doing very well in the conservative management, I'll keep them the way it is. But on the other hand, this guy coming back to me said, Dr. Do Ouro, I did the epidurals, but it's only lasting a week. What I can do, my meds are not working. I need more meds. So that the patient have to think about a neuromodulation, either a pump, either a dorsal column stimulator. And they don't have to wait until they really have felt anything. And so that's why a lot of doctors, they don't go in so high doses of an opioid because it has something else to do. So that's why Portnoy can go to 2 grams of morphine because it's the only thing he can do. I mean, that's in his hands. That's why you go into a neurologist and they put you on Medropac, despite that, because that's what he can do for you. He cannot say, I'm going to give you an epidural and you're going to get better. So there the patient's complaining, I can walk, my back. So the doctor's going to work with the tools they have in their hands. And that's why you have different tools. So you're going to have different options of treatment. So you have to consider patients of dorsal column stimulator much earlier than we did in the past. And I noticed that actually those patients do better because they're not really so much into their pain syndrome. They're not much more like a chronic pain patient. They have much more chances to rehab and to really go back into their social life and the activity level. Okay, this is another study that was very important in North, done in 2007. He also did 50 patients with Fehlback syndrome, and he's doing economic data. So really showing that it's effective operating these patients. And this is a two-case presentation that I want to present to you guys. It was really very different for me. And one is he's still coming into my office. I can present to you guys anytime, introduce to him. He was 36 at that time. He has 90 years history of right flank pain. It was really localized in the flank, and he had him in multiple stones passing due to cystinuria. And throughout those years, he developed this pain that we believe is being neuropathic due to probably a lot of scar tissue formation, compressing some peripheral branches and so on, because it was very burning, typical pain. But it wasn't back pain. It was just flank pain at the level of the kidneys. Very different. This patient have no life. He's a young guy working in Wall Street, going to work in the morning, come home in excruciating pain, going to bed, sleeping throughout the night as much as he could, a lot of drugs. Once he was taking 16 tabs of oxycodone a day, plus methadone, plus fentanyl. So try fentanyl lollipop, try everything. It was like, Dr. Do Ouro, just enough to go and work to survive and get my kids their survival. He had 2 boys. He said, I don't play with boys. I don't do anything else. I get home, I go to bed. So I even had a question. This is a very nice guy, a very, good-looking, young guy. He said, there might be something else. And so I didn't understand why it wasn't getting better. Medications have to be changing medications. And I had a lot of resistance to do a stimulator because flank area, very difficult to cover, and the etiology is very unclear. How neuropathic is this flank pain? I didn't know exactly what I was dealing with. So after so many other attempts, I called the wife. The wife came to the office. We sit down and said, listen, you want to tell me, there is anything else going on? No, Dr. Do Ouro, we're doing fine. We just don't have a life. And she said, do you think you want to go through this? We might have a chance not even to get coverage. Well, it's our last chance. So I put this patient in the room. It is interesting that I noticed during my trials that it seems that when the patient does have problem in the area, it seems that we can get a better coverage, like for areas that usually I wouldn't get it if the patient doesn't have it. And he got coverage. As soon as we put the leads in, we got good coverage in the flank. I was even like, okay, it seems like really too easy to be true. It's that was many years ago, 2007. He's still coming in. He only takes 30 milligrams of methadone a day. 10 in the morning, 10 in the night, 10 afternoon. No breakthrough meds. He's having great time. Send me pictures every year of their vacation. Very happy. Pain reduction by 80%. He's the happiest guy ever. So it was really it has been a very pleasant experience for me as a physician, see this change. Okay, this is a new guy who need that, and it's amazing. It's really amazing if you look to everything else. So yes, as a pain specialist, you're going to have to do your good indications. But there is sometimes you have to go out of the box in situations like that and see, okay, nothing else is happening here. This patient has no life. What can I do to make it better? This is another one. She's a nurse. She came to me with 7 years diagnosis of multiple sclerosis. Also not a typical diagnosis for dorsal column stimulator, and has neuropathic pain affecting her right leg, and also there was some pain on the thoracic level. So it was very interesting, her trial, because I put the lead, I went to T4, and we started to stimulate it, and we couldn't have, she didn't feel anything. No, I don't feel anything. And the rep is looking at me, and Dr. Do Ouro, the impedance is good, we have no problems with connection. I went to 12, and she doesn't feel anything.